Okay, thank you everybody. Really glad to be here today with everybody and really grateful for the opportunity to present some of my research. My name is Jimmy Carlucci. I'm at Indiana University and I'm presenting this research on behalf of myself, my co-authors, and the International Epidemiology Databases to Evaluate AIDS, or IeDEA. And I'm presenting our work entitled High Prevalence of Unconfirmed Positive HIV PCR Test Results Among African Infants with Perinatal HIV Exposure in the IeDEA Consortium. And I'm going to mostly read to you so that I stay within my 5 minutes and don't fall through the trapdoor. I have no conflicts of interest to declare. And so getting right into it, as you know, the scale-up of vertical transmission prevention services has dramatically reduced incident infections among infants with perinatal HIV exposure. However, as vertical transmission declines, the positive predictive value of infant HIV testing also decreases, and the probability of false positive test results increases, highlighting the importance of performing confirmatory testing for all positive or indeterminate tests to help confirm HIV diagnoses prior to starting antiretroviral therapy. And if confirmatory testing is not performed, infants might be misdiagnosed with HIV and unnecessarily started on lifelong ART. So the objective of this study was to determine the prevalence of unconfirmed positive HIV PCR test results among African infants with perinatal HIV exposure in the IeDEA Consortium. And to accomplish this objective, we carried out a retrospective analysis that utilized pooled data from clinical sites in 4 IeDEA regions: Central Africa, East Africa, Southern Africa, and West Africa. And we included infants born between 2004 and 2021. Infants with only one positive virologic test, so those with a qualitative or quantitative DNA or RNA PCR at less than 18 months of age, and who had no additional positive virologic or antibody tests at 18 months or older, were considered unconfirmed positives. And our primary outcomes were the percentage of unconfirmed positives among all infants with perinatal HIV exposure and among those with any positive virologic test at less than 18 months of age. And among unconfirmed positives, we also describe virologic testing, or lack thereof, that was performed at any time after the initial positive result. As you can see in this figure, this analysis included over 72,000 infants with perinatal HIV exposure, and overall 3,652, or about 5%, had at least one positive virologic test at less than 18 months. And 1,600, or 44% of those lacked a confirmatory positive test. Among these unconfirmed positives, the vast majority lacked additional virologic testing at any time after the initial positive result. However, 217, or 13% of those unconfirmed positives did have additional virologic testing that was not positive. 166 of these had one or more DNA PCR that was negative or indeterminate. 50 had one or more RNA PCR that was undetectable, and 1 had both DNA and RNA PCRs that were negative. In this slide, which stratifies the cascade by IeDEA region, you can see that there was some regional variability with unconfirmed positives ranging from 13% of infants with any positive virologic test in Southern Africa to 91% in West Africa. And in this figure, we illustrate the percentage of unconfirmed positives among all infants with perinatal HIV exposure stratified by year and region. And while there was some variability between regions and from year to year, you can see that the overall trend is that unconfirmed positives appear to be less common in more recent years. So in conclusion, unconfirmed positive HIV test results were highly prevalent in this cohort of African infants with perinatal HIV exposure, and additional efforts are needed to ensure confirmatory testing to reduce the risk of potentially false positive results. And next steps will include investigating the context in which these unconfirmed positive results occur, and to determine whether unconfirmed false positive results might have led to misdiagnoses that need to be addressed. And so briefly, I've just listed the funding sources that have helped support this work, and I'd also like to thank my colleagues, my collaborators, my mentors, of course, the healthcare workers who are on the front lines of caring for these children and for collecting these data. Thanks.